On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speakers, Paige Swales and Nancy Engellenner. So Paige has a BS in Health Education and Behavior from the University of Florida and an MS in Nursing from Wilkes University in Pennsylvania. She received her Certified Nurse Midwife degree from the University of Florida in Jacksonville and is board certified by the American Midwifery Certification Board. Along with full-scope midwifery services, she also provides general women's health and gynecologic care, including well woman exams, general health checkups, and testing, family planning, and adolescent gynecology. She sees patients at Foothills Community Midwives in Boulder and in Erie. Nancy received her bachelor's degree in nursing from the University of Colorado. She completed additional training with the University of Texas MD Anderson Cancer Center. She is a certified women's health care nurse practitioner and is recognized as an advanced practice nurse by the Colorado State Board of Nursing. She specializes in diagnosing and treating the full range of health and wellness concerns for women of all ages. She sits on several medical committees and enjoys sharing her knowledge about the latest research and innovations in the women's health field. She sees patients at Boulder Women's Care. Welcome to Paige and to Nancy.
Hi, I'm Nancy Engellenner, and we'd like to get started with our HPV presentation. We go over some disclaimer first. We have no financial relationships to disclose. Our objectives for tonight is to hopefully give you a better understanding of HPV, which is human papillomavirus, its history, its prevalence, the transmission, the prevention, and the treatment. We'd also like to talk about the vaccine, which is when I'll turn the presentation over to Paige. We'll discuss who, where, when, why, and the efficacy of the vaccine. First, what is human papillomavirus? It's commonly referred to as HPV. It is a huge group of strains of the virus. It exists worldwide. In certain areas, you'll find different strains more prevalent than others. We are going to address the more prevalent strains for the United States. It is the most common sexually transmitted disease. There's over 200 strains of HPV, and approximately 30 of them will affect us genitally. Some of those are high risk, some of those are low risk. The high risk ones can cause cancerous changes, and the low risk ones can cause skin changes such as warts. And we'll share with you some pictures of these changes later on in the slides. Our concerns genitally and orally regarding HPV is cervical cancer, penile cancer, anal cancer, vulvar cancer, and oropharyngeal cancer. There are almost 43,000 new HPV-associated cancers every year in the United States. There's probably millions of HPV diagnoses that don't lead to cancer. Breakdown of the new cancers varies significantly for males and females, of course, with females having cervical cancer as the most common type of cancer that it produces. As you can see on the slide there, it's 49%. Females also have more anal cancer than males, 18%. And then it goes to vulvar cancer, which is 16%, and vaginal cancer and oral pharyngeal cancer. So of the new cancers that are diagnosed related to HPV, you can see that women have over 25,000 of them. Males have almost 20,000 of them, and their main cancer is going to be oral pharyngeal, followed by anal cancer, most frequently in men who have sex with men, and penile cancer, which is about 7% of those cancers. Most HPV is going to resolve spontaneously. 80% of us, by the time we're 50, will have had an HPV infection. Usually they're gone within 12 months and don't require any additional treatment. There is some theories as to whether or not there's a latency factor with HPV where you may be exposed, you didn't have any symptoms, it was never detected, and then years later you may all of a sudden have a diagnosis of HPV. Not all of these HPV diagnoses are going to lead to cancer. Because as I said, 80% of us will be diagnosed and 80% of us are not getting a cancer. The peak prevalence in the age that you're going to see HPV infections is going to range from 15 to 25 years old. And it usually occurs within 10 years of your sexual debut. In other words, the first time you had intercourse. And as I said previously, 80% of these people will have HPV by the time they're 50. The transmission is skin-to-skin contact, so you can have close, intimate contact and transfer warts. Penile vaginal sex, you can get cervical cancer, vaginal cancer, and vulvar cancer. Anal intercourse, you can get anal cancers, and then some of the prevalence, some of the prevention that we have for it is just like we prevent any other disease that we have. Take care of yourself. Keep your stress down. And just, eat right, don't party too hardy, and limit the number of partners you have, and think about getting the HPV vaccine. And I'm going to turn it over to Paige now to talk a little bit more about the vaccine.
Hi, thank you guys for being logged on and listening. We're really glad to have you all participating in our lecture tonight. So I'm going to start off just by talking a little bit about the prevention and more focusing on the vaccine portion. As Nancy said, it is so important for really any virus that somebody can get is to help prevent that is to take care of themselves. So that's going to go back to really basic stuff like Nancy just mentioned, like making sure you're sleeping, avoiding tobacco and drug use, and making sure that you keep your immune system up and those sort of things. So I think that goes back to really basic, just well care, self-care is really important. So we always encourage that as the first line. And then for this specifically, we're definitely recommending the vaccine. And so some of the points that I wanted to make sure that we covered tonight is who can get this? Males, females, age ranges. I really want to go over that. And then where do you go about getting this vaccine? Great. One thing that I did just want to mention is the next part of this presentation does have some photos and or slides that may contain some graphic photos. So just be aware over the next couple minutes that you may see some pictures that are very graphic. So why do we do screenings, and why are we preventing, why do we want to prevent this virus? So the first thing I want to talk about is some treatment. And so how do we screen for these things? As Nancy pointed out, with the high prevalence of cervical cancer related to HPV, it's really important for females to be sure that they're getting their routine screenings involving a PAP and/or HPV screening, and that is really dependent upon age. We look at the American Society for Colposcopy and Cervical Pathology that give us guidelines for when, how often to do screenings. And so based on age and risk factors as far as repeat screenings or abnormal findings, that would indicate when you go in and when we would recommend that screening to take place. And then we'll talk a little bit about appropriate follow-ups. So if somebody were to come in and have an abnormal pap smear or have abnormal cervical cells, or if you were to see external genital warts, what do you do about those findings? So, appropriate follow-ups for abnormal findings can be something as simple as repeating a pap smear in 1 to 3 years, doing a colposcopy, which is a more invasive exam that sometimes can include biopsies that are sent to pathology to really look at those cells. Cryotherapy is another form of follow-up regarding abnormal findings. And then a LEEP, which is a procedure done to remove those abnormal cells, is another form. And then there are more extensive excisional surgeries that can be done. And all of these would be something that you would have a long conversation with your healthcare provider about, and making sure that these are the appropriate follow-ups that are needed based on the pathology that is detected. The treatment of warts. So as Nancy mentioned, the human papillomavirus, we have a couple there's a lot of different strands, but some are high risk and some are low risk. And so the low risk HPV strands are the ones that can lead to genital warts. And so not only are those warts, they can be males or females, they can be in the vagina, they can be on the vulva, they can be on the penis, around the anus, they can be really anywhere, or pharyngeal as well. Those would not be genital warts, but you can get condyloma in all sorts of places. Not only are they aesthetically displeasing, but they can be painful and uncomfortable, and they are extremely contagious. So the next couple slides are a little graphic, so just kind of bear with me here. So as you can see, penile warts are located in this picture, and they're definitely not aesthetically pleasing, and they are extremely contagious, not only for transmission, but also for yourself. So if somebody does have, they may start off with one wart, but because they're so contagious, it might lead to 2 or 4 or 10, and they can get really, really extensive. And so we do encourage people, if they have any abnormal findings or feel uncomfortable or start to notice things, that they reach out to their healthcare provider. That way they can be seen, and we can take care of these. This is a picture of vulvar warts again. You can see that there's a little cluster in this picture. It may have started off as one, and then because of the extremely contagious actions that they have, they definitely spread and grow. And so before you know it, it can turn into a very large group of warts that become more extensive to remove and treat. So these are some perianal warts, and this is kind of a good picture of how it can turn into if you don't get them treated. And this is something that, you might start off with one and a year later still have one, and it could also happen in a couple weeks. You have one and then you have 50. So it's definitely important, if you notice any abnormal findings on your body or your genitals, that you reach out to your healthcare provider. So a little bit about cervical cancer. It is the 4th most common cancer in females, and it is one of the most preventable cancers with our screenings now. Breast, lung, and colorectal are obviously more common, but it's important to know that with the screenings that we have that are fairly simple, it's really important to get females in to their women's health practitioner or their primary care to get screened for cervical cancer. Virtually all cases of cervical cancer are from HPV, and what we do know is that approximately 50% are from the strand type 16, and about 20% are from type 18. This is a picture of what cervical cancer can look like. So this is one of the reasons we encourage young females to come in at an early age, because this is not a healthy cervix. And women that come in on a regular basis get pelvic exams, and they may not be necessarily due for a pap smear, but it's important to do a lot of teaching and education, especially for young adolescents who may have newly become sexually active, and it's important to show them what a healthy cervix looks like and teach them good habits and prevention mechanisms to help prevent things like this. So I always encourage our families, if you have a daughter or a cousin who you know hasn't been to see a gynecological provider, I always encourage to set up a visit and get in to be seen so we can show you what's normal and healthy. That way we stay like that and we prevent things like cervical cancer. Anal cancer. So 90% are from HPV virus, mainly 16 and 18, and women actually have higher incidences of this than males. And then oropharyngeal cancer. I think a lot of people think of this cancer as being tobacco-related or smoking, and that definitely is part of the definitely some of them are related to that, but actually the majority of oropharyngeal cancers now are related to the HPV virus. So again, this is maybe not necessarily a women's health provider, but this is like routine primary care checkups and dental screenings, because it could start off as something as really small as a white spot on the roof of your mouth or on the back of your tongue, and then it can really quickly lead to a mass or extensive lesions that could be, that require much more invasive treatment. The other thing that I wanted to mention is Nancy had mentioned the number of new cancer cases each year, which is astounding that it's almost 43,000 new cases of HPV-associated cancers. That is that's like more than one case every 20 minutes. And so when you put it into those words, it seems crazy to think that if we could, educate our future generations and prevent this virus with a vaccine, that we just need to be more assertive and get people on board. So I hope that I'm answering any questions you guys might have about the vaccine today. So a little bit about the evolution of the HPV vaccine. So in 2006, Gardasil 4 came out, which was the first HPV vaccine, and it protected against 4 different strands of HPV, which was 611, which are low risk, they can cause genital warts, and 16 and 18, which we have mentioned are one of the highest cancer-causing types of HPV. 2009, another company came out with Cervarix, which was 16 and 18, mainly prevention of the high risk. And then in 2014, Gardasil 9 was put on the market, and this is the one that is used here today in the United States. And this is the one that has the most extensive coverage, and as you can see, it still doesn't cover, of all the different strands of HPV, it still doesn't cover that many. 6, 11, 16, 18, 31, 33, 45, 52, and 58 are the types that it is covered. This is the vaccine that is available here in the US, and the big question, is it safe? So many people have concerns about about vaccines, and there's extensive vaccine reporting systems and studies that are done on vaccinations. So as healthcare providers, we definitely recommend the Gardasil number 9. So there's 4 different safety vaccine systems. The first one is called VAERS, And I'm happy to share this information. If anybody wants it, we can privately email this information out. But this is a combination between the CDC and the FDA. And this is like spontaneous reporting of adverse events. And then there's also the vaccine safety data link. And this is between the CDC and 8 integrated healthcare systems. There's also the clinical administration safety assessment, which is the CDC and then 7 different academic institutions. And then there's the post-licensure rapid immunization safety monitoring program. And this is the FDA and then 6 partnered organizations. So there's lots of different ways where we track adverse reactions or events related to vaccine safety. And so Gardasil has been proven to be safe. Up until 2018, so for the first 4 years that Gardasil 9 was on the market, it was only approved through ages 9 through 26. And then in 2018, it was then extended to the age of 45, which is very exciting. And I'll elaborate a little bit later on why it's now important to also vaccinate, to extend the vaccination age. So now males and females, this vaccine is available and recommended for those ages 9 through 45. And ideal age is males and females between the ages of 11 and 12. And mainly this comes from we want to give the vaccine. We want to have males and females get this vaccine prior to the onset of sexual activity. So why would we say that it's good from 9 to 45 if we're really not giving it until ages 11 or 12? There are special circumstances where it would be recommended to get the vaccine a little earlier. Those situations might be abuse or social situations. Everything is kind of case by case, and I think it's really important to discuss the need or desire to get a vaccine with your healthcare provider. It's also important when your healthcare provider is going through questions like taking a health history, just to be sure that you're disclosing any and all information to them. That way they can determine what the appropriate and best age is for the patient. So per the CDC, there is an immunization vaccination schedule. There's a really nice chart that is accessible online. Most health departments, vaccine clinics, pediatric offices, women's health offices have copies of this chart in their office, and it kind of breaks down like on when people should get vaccines. And so the CDC is recommending it between ages 11 and 12, and I think some of that just has to do with other ages of getting vaccines. There is some off-label use, which just means it doesn't mean you can't get the vaccine if you're 46 years old or 52 years old. It just means that it's been approved, which means it's been studied and safety has been shown from 9 to 45. So where can one get these vaccines? Of course, BCH has multiple offices that provide these vaccines, but also pediatric offices, public health or county health departments. Any type of vaccine clinic is going to be able to offer these to you. Family medicine, internal medicine, primary care offices will also be able to access these vaccines for their patients. And then women's health care providers. And then, like I said, of course, at BCH, our primary care offices, as well as some of our specialty clinics, including Boulder Women's Care and Foothills Community Midwives, offer these vaccines to their patients. So when to get it? So I chatted a little bit about, of course, it's approved 9 to 45, but again, it's ideal to administer this vaccine prior to the onset of sexual activity. So again, that's why it's important that we go back and really focus on the individual patient and their health history and their risk factors, and maybe earlier timing would be more appropriate if somebody had a certain situation that indicated that it would be best to give it prior to the ages of 11 and 12. Usually, based on the CDC recommendations, it's given between the ages of 11 and 13. There is some interrupted scheduling kind of things, and there is different dosing depending on the age that it's given. So as you can see on the slide, it says if you're less than 15 years old, you'll need 2 doses. So you would get your initial dose and then the second dose between 6 and 12 months later. And because their immune system and their response to this, they only need 2 doses. If you're over 15, we recommend 3 doses. That would be an initial dose. The second dose would be approximately 2 months later, and then the third dose would be 6 months from the initial dose, so 4 months after the second dose. Some information, like obviously if the vaccine schedule's interrupted, so say for some reason you were out of town or you missed your appointment, or a pandemic was in place and you couldn't get to the office to get your second vaccine, the series does not need to be restarted. No additional dose is recommended after completing a series. Recommended dosing intervals using any of the HPV vaccines. And like I mentioned, there are special or certain circumstances where we would recommend getting the vaccine prior to the age of 11. And again, that's something that I think that you should talk, and it should be based on individual risk factors and definitely be discussed with your healthcare provider. So why? Why do we want to protect against this virus? The number one reason is cancer prevention. So, and like, how does our body take care of that? So with this vaccine, the goal is to have an antibody response to these types of HPV, depending on which vaccine you get. And so the HPV types, you should have an antibody response approximately 1 month after the series is completed, and 98% of those people will have that response. It is almost 100% effective in reducing the HPV strands that are listed under the vaccine. So for the Gardasil number 9, it is 6, 11, 16, 18, 32, hold on, 31, 33, 45, 52, and 58. And so these are almost 90% effective in reducing cancer, and over 70% effective in reducing the incidence of genital warts. Okay. So some of the references that we used to obtain this information for this presentation come from the CDC, which is the Center for Disease Control. They have really great vaccination and immunization charts that I would highly encourage all of you to look at, just to be sure that you or your loved ones or your sisters, brothers, cousins, children are at appropriately following those. Gardasil number 9, they actually have a website where you can go to and read about the efficacy, the studies. And so looking at their website, we obtained some of this data. The World Health Organization goes through a lot about the human papillomavirus, cervical cancer prevention, and also goes into great detail about the vaccine itself. And then the American Academy of Pediatrics.
So that concludes our presentation. We are very open to questions, and if you have put them in the chat box, Karen will read them and we will try to answer them for you.
Yes, thanks for coming and listening.
Thank you for tuning in.
Yes.
Thank you for the presentation. That was very informative. We appreciate that. We are going to move into our Q&A portion of the lecture now, and I'll ask some questions, and I'm not sure how you want to answer it. I'll let you guys either take it or nod to each other to do that.
Great.
And they just are random here. All right.
Great, thank you.
So how would I get my 12-year-old son in to see you?
We, Paige and I, don't see males in our practice, but they can be seen at their pediatric office or with a family practice provider. He can be seen at the health department. And that's usually the way that they'll get it, usually is with their primary care provider.
Okay, thank you. Why get this vaccine when you're older and have been sexually active?
Because you may not, the chance of you being exposed to every one of the strains that it's protective against is very low. So even if you have been exposed to 5 of the strains in it, you still have another 4 strains that you can be protected against.
Okay. So a couple things about COVID. Are there any special precautions when visiting you with COVID restrictions still in place?
Sorry, can you repeat the question?
Any special precautions that patients should take when visiting you because of COVID?
That's a great question. So currently, BCH does have some limited visitation as far as accompaniment in the office, but we obviously recommend wearing a face mask, using social distancing when you come to the office. But as far as getting appointments,
Hand wash.
yes. But as far as getting an appointment, you would just call one of the offices and get scheduled, and then, use good hygiene, hand washing, wear a mask, use social distancing, and then when you get into the office, it's the same.
You get the same screening you get at every other place that you go, and you have your temperature taken also. And if you're ill, we request that you don't come.
What about taking this vaccine close to when you're getting your COVID vaccines? Should you wait a certain amount of time in order to get this vaccine?
That's a great question. Thanks, Karen. So the question is should you wait between the COVID vaccine, or is there any special time that you should have in between getting the HPV vaccine and the COVID vaccine? In general, the CDC is recommending 2 weeks in between vaccinations. So if you just received your COVID vaccine, we would wait until you had 2 weeks post-vaccine to get the Gardasil vaccine, or vice versa. If you got the Gardasil, we would encourage you to wait 2 weeks prior to getting your COVID vaccine.
Great.
And as Paige spoke to when she was reviewing the vaccines and when to get it, the scheduling, you just pick up where you left off. So if you got the COVID vaccine and that put you 2 weeks later to get your next one, it's fine. Your next HPV, it's fine. You just get it, and then you do your next one at the correct time schedule.
Great. Are there any side effects with the vaccine?
There's a sore arm for some people, and that's usually the most that you're going to see from it.
Yeah, along with any intramuscular injection, there can be some redness, some irritation, and definitely some muscle soreness. But for the most part, most people do fine and don't have any adverse reactions, but that would be a great place to go check out the Gardasil 9 website, and you can look onto their vaccine safety and adverse reactions, and you're able to access that. But usually a sore arm for a couple days is probably the biggest, report that we get.
Okay. So as part of the presentation, you had some scheduling information, maybe 6 months apart for the vaccines and some other details. But how fast does a vaccine work? Is there some efficacy for the first shot as there is for the COVID shot, or really not full efficacy till the last shot, and again, how far after that last shot?
So there is some efficacy with each injection, just like you got with COVID vaccine. And then 1 month after receiving the last Gardasil vaccine is when you have that 97% effectiveness. So it's not long after. But you do get some with each injection.
Okay, thank you.
You're welcome.
So is it one and done? So you can take it at 11 years old and you're done. You could take it at 45 and you're done.
No. you can be done, but it's probably better if you get all three so that you get the best immunity. But if you're under 15 when you're receiving the second vaccine, you only need 2. So if you're under 15, you'll have the initial, and then usually between 6 and 12 months, you'll get your second one, as long as you're still 15 or under. But you don't want to do it before 5 months. You really do want to wait that 6 to 12 months to get it for the best efficacy. And then the others, if you can do them on a time schedule, we're going, that is a recommended initial 2 months later, 4 months later, so a 6-month period of time, you're going to get your best efficacy. And they didn't really study, oh, you got this one at 1 month, this one at 3 months, this one at 6 months, whether or not it was the same effectiveness. They studied it when it was given on the schedule.
The other thing to mention maybe about the vaccine is there is no recommendation at this time to repeat the vaccine later in life. So if you did get it at the age of 12, at this time there's no recommendation to get the vaccine again, to have it administered again later.
There's also questions we get frequently about women who were in the initial vaccine era in 2006, and they got Gardasil 4. And so they did not get Gardasil 9. So should they go ahead and get Gardasil 9? And that information is very difficult to, there is no succinct recommendation for it. If they want to get the 9, if it's going to make them feel better, it's not going to hurt them to get it. So there's a small group out of there, probably the 35-year-olds, that if they got it when it first came out. And the interesting thing, when it first came out too, it was not recommended for boys, males. So that was a big leap when we included males in the vaccine schedule, in being able to combat this virus more and decrease the risk of cancers in both males and females.
But your presentation did mention that it is more common in women versus men. Is that correct?
It is for most cancers. We do see it. I mean, we see 25,000 of women and 20 in men of cancers, and that part of that has to do with the type of tissue that women have. Our tissue is, especially vaginal tissue, is more easily torn. So it gives a entrance point for the virus, and that's why you see with men who have sex with men, you have a much higher anal cancer if they're receptive to anal penetration. They're going to have more tissue damage in that delicate mucal membrane that you see with the vagina.
Also, women's anatomy is a little hidden compared to men's anatomy, and so it's not as obviously seen sometimes. So that's why, again, we stress the importance of routine screenings, being seen by a provider, and that's for women, but it's also important for males to be screened by their primary care provider. There's also, sexual and reproductive health clinics in most communities where men and women, males and females, can both go for exams. And, personal detection is also a great thing. If you see something that has never been there before or looks different, it's always important for you to report those things to your healthcare provider.
Why get the vaccine when you're older and have been sexually active?
If you're having new exposures, it will give you some protection against the strains of the virus that you have not been exposed to and do not have. So your immune response is not as good when you're 11 and 12, but it definitely gives you some immune response and some immunity.
But not to the ones that you've already been exposed to?
No.
Will condoms or other birth control negate the need for this vaccine?
So so the question is, would condoms or other forms of birth control negate the need for this vaccine? And the answer to that is no. So as Nancy mentioned, with transmission, it is skin to skin. So unfortunately, this virus, though condoms protect from a lot of different STDs, they don't 100% protect from HPV because it is skin to skin. And birth control will protect you from pregnancy if used correctly, but not from viruses or infections. So it is definitely important to be aware of this virus and to use protection as much as you can. Barrier methods do decrease the transmission, but not 100% protect you from getting it. So just important, and that's why we recommend the vaccine.
So if your partner had a wart and it's been removed, is the risk gone?
So the question was, is if your partner had a wart and it was removed, is the risk of HPV gone? The answer to that is no, because that virus is still present in that person's body. I think the transmission is lower, being that there's no active wart and or lesion, but the risk is not eliminated by any means. And so it's important for you to still use barrier methods to help prevent this virus transmission.
And this is typically, again, a vaccine given by gynecologists, is that correct?
No, multiple providers in our town and any town across the country are going to give it. I mean, GYN providers, women's health providers, pediatricians, primary care providers, health departments, multiple providers can have it. It's easy to access, and if you have any problems with that, you are always welcome to call and we'll direct you to a facility that you could get it with. But it's not just gynecology.
Is it typically covered by insurance?
If you're within the age 9 to 45 years old, male or female, it is covered by your insurance if you have preventative care. If you don't have preventative care, sometimes they don't cover vaccines. So it's very individual with your policy, but it is eligible for coverage if you do have immunization coverage in your policy. But off-label use, you can pay out of pocket for it, and sometimes insurance does cover it. I don't know if it's a mistake or if they just feel that immunizations, you can pick and choose the ones you want. So
I would definitely, if for some reason you don't feel that you have coverage or health insurance or coverage for vaccines is a concern, I would consider reaching out to your local health department, vaccine clinics. Also, just talk to your primary care or your GYN provider and talk about cash pay and other resources in your community, because I feel like there are always places that do offer discounts or do have some sort of coverage, whether you have insurance or not. So definitely case by case, reach out to your healthcare provider to get more information.
They have vaccine for children programs you can get through the health department, and these are all covered through those. Some Boulder Valley Women's Health, Planned Parenthood, some of them have less expensive vaccine or coverage if they have a grant.
Perfect.
Yeah.
So is there anything else that you'd like to say before we wrap this up?
Nope, I encourage all families to look into this and to speak with your healthcare provider, get more information if you're not sure. You can reach out to us here at BCH, but definitely feel, we all want you to feel comfortable reaching out and asking questions and making sure that this is an opportunity that you take advantage of. So definitely, if there's anything that we can do to help get you or a family member on board getting this vaccine, we want that for you. So just reach out to us, and our names and numbers were at the beginning of this presentation, and you're welcome to call our offices to get more information.
The other thing to remember too is this virus is very prevalent. A lot of people will get it in their lifetime. You don't need to feel badly that it happened. You do your best to prevent it. Like I said, sleep right, eat right, don't party too hardy, limit the number of partners you have, use condoms, and get the vaccine. But if you think you have something going on, don't be ashamed to come in and get checked. We see it all day long, every day, and we're just here to help you and keep you as healthy as possible. Thank you.
Yes, thank you so much for your time this evening. We appreciate you listening, and hopefully we'll see you guys soon.
Thank you, Paige. Thank you, Nancy.
You're welcome.
We've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Again, please visit bch.org for information on the COVID-19 vaccination. Thank you for joining us, and have a good night.